Today, we are covering nutrition and therapeutic diets, a topic the NCLEX loves to test through application-based scenarios. You will rarely be asked to simply define a diet. Instead, you'll see a patient scenario and must identify the correct, or more often, the incorrect, dietary choice that requires you to intervene. Let's take a client with chronic kidney disease, stage 4. Their lab results show a potassium level of 5.9 milliequivalents per liter and a high creatinine level. The exam will ask which meal selection by the patient requires further teaching. The options might be baked chicken with rice, a green bean salad, a whole wheat dinner roll, and a side of fresh cantaloupe. The answer is the cantaloupe. The NCLEX expects you to know that patients with kidney disease cannot excrete potassium effectively. And cantaloupe, along with bananas, potatoes, oranges, and tomatoes, is dangerously high in potassium. Another common trap for renal patients involves salt substitutes. A patient might say, "I'm avoiding salt by using a salt substitute." This is a major red flag. Salt substitutes are made of potassium chloride, which can be lethal for a patient with hyperkalemia from kidney failure. You must intervene and educate them immediately. Now let's contrast this with a patient who has heart failure. Their primary issue is fluid volume overload. So, their diet will focus on sodium and fluid restriction. The exam will test your understanding of this with questions about hidden sources of sodium. Think canned soups, processed lunch meats, frozen dinners, and condiments. A question might describe a heart failure patient's food diary. The entry that requires intervention isn't just the bag of chips, it's the canned tomato soup they had for lunch, which is loaded with sodium. For fluid restriction, the key is understanding what counts as a fluid. It's anything that is liquid at room temperature, which includes ice cream, gelatin, and ice chips. A common trick is that ice chips are counted as half their volume. So, if a patient has 100 milliliters of ice chips, you document 50 milliliters of intake. The most accurate indicator of fluid status and a frequent correct answer on the NCLEX is daily weight, not the intake and output chart. Now let's quickly touch on nutritional support. For enteral nutrition or tube feeding, the #1 priority before starting any feed is to verify tube placement. The gold standard is an X-ray confirmation after initial placement. For subsequent checks, you will aspirate gastric contents and test the pH, which should be 5.5 or less. For total parenteral nutrition, or TPN, the two biggest risks are hyperglycemia and infection. You'll be monitoring blood glucose levels frequently, often every 4 to 6 hours, and you will use strict aseptic technique when handling the central line, as the high dextrose solution is a breeding ground for bacteria. To help you remember the key restrictions for a renal diet, use this phrase: for kidneys in trouble, avoid the 3 Ps. This stands for potassium, phosphorus, and protein. The NCLEX will test your ability to connect these restrictions to specific food choices, ensuring you can keep your patient safe. Your job is not just to know the diet, but to anticipate the patient's most likely and most dangerous mistakes.